Now with Dr. Lina El-Shirawi, consultant orthodontist, special in dental lasers, and international advisor for Royal College Scientific of Edinburgh from Bahrain Kingdom. Welcome, Dr. Lina, with complications of orthodontics and the heterogenic effects of orthodontic treatment. Go ahead.
Thank you so much, and good afternoon, everyone. Before I start, I would like to know how many of you are dental students? Can you raise your hand? Okay. And how many of you are just freshly graduate or general dentists? So I assume the rest are specialists and consultants? Yeah? Okay. Because the lecture here, the target audience are general dentists. As I was told that the audience will be general, so I hope I won't bore those specialists and consultant orthodontists or in any another. So this is just a brief of my journey. I might look young, but I'm not young at all. I would like to start with this because I would like to give all my appreciation to some personnel who have printed their fingerprints on my life. So when I was in Egypt, Dr. Gasser, Allah yarhamah, he was the one who touched me a lot. And then I went to Bahrain, I did my internship there, then worked in the private center, and Dr. Manam Hafad was the reason behind which I studied orthodontics. Then I went to King's College, University of London, and Royal College of Edinburgh, and those people have really touched my life and my career, and most of them was Prof. Meikle and Prof. McDonald's. Then went back to Ministry of Health, and then decided to go to the private sector where I started my dental practice, to Smile. Then in 2013, I decided to pursue my education, do more. And I contacted Prof. McDonald when he told me, if you want to come, then you will do PhD, and that's for 5 years full time. I didn't have the full-time leverage to go over there, so I decided to do lasers, masters in lasers, and that was in Germany. And these are my colleagues and my professors. Then we rebranded our clinic into Signature Dental Center. Something is going on? Okay. And then I was elected by the Royal College of Surgeons to be the international advisors for the Royal College of Surgeons of Edinburgh. I'm speechless when it comes to this guy. He taught me everything. He taught me to think, to evaluate the paper in front of me. So not just take anything for fact because it was published in papers. For that, I did wrote once, Albert Einstein said, "It is the supreme art of a teacher to awaken joy in creative expression and knowledge." He didn't know by that he was describing my professor, Professor McDonald. And I'm really honored to be working with him right now. And then in 2018, I was elected by the ICD, which is the International College of Dentists, which is the headquarters in Washington, D.C., to be awarded an honorary fellowship. And I am the only one in Bahrain to be awarded this fellowship. You cannot have this fellowship unless you're nominated by 2 members, at least 2 members, and you will be going through a civil investigation until you are accepted. So, going to my lecture. Something is going on. Okay. So everyone knows what is an orthodontic, since we are all dentists here. But orthodontics, as a general, is a branch of dentistry which will look after our general health, our overall quality of life, because we do improve facial aesthetics, we improve psychology of a patient, we do improve much more than just aligning teeth. For that, I think it's my problem. It's not the pointer. For that, we have to weigh the benefit and risk before we start in orthodontics. I will tell you why did I choose this lecture at the end of the lecture. If the benefit overweigh the risk, obviously we're going to do the orthodontic treatment. But if the risk overweigh the benefit, then either we do not do treatment, or we alter our objective of treatment, or then we will have to accept any, let's say, shorten in the outcome of the treatment. So how can moving teeth within a bone can cause a damage for a patient? For that, we have to know what is the success rate in order to know what are the risks and complications. And the success rates are two different parts. It's either related general factors or related to the appliance. The general factors is the patient in front of me as an orthodontist, and the communication between me and the patient and their parents. The general factor is related to the appliance we're using. So I won't go into details. But a patient, for example, if a patient come at a younger age, like let's say 12 years, he's just a teenager, I have to evaluate his cooperativeness, what type of malocclusion he has, his psychological behavior, his parents' attitude, and all of these going to affect timing of my treatment, objectives of my treatment, choice of appliance, duration of the treatment. I will also affect any problem that can be caused to the patient teeth and my outcome results. An orthodontist should be knowledgeable, knows what he does, and I think all the three lectures before me were evidence-based, and for that, they show you that you cannot do anything except that there is an evidence behind it. You cannot just say, okay, I'm going to try this for this patient or for that patient. You have to know where are you going. From the start, you know, I'm going to move this tooth from here to here. I'm going to have this movement happening. I'm going to have this or that. So you have the end at the beginning. The end of the treatment is in your mind at the beginning of treatment. Patient-doctor relationship, then that's basically emphasis on the communication between me and my patient. If the patient knows really what I want to do and he knows what is expected from him, then the treatment is going to succeed. Otherwise, we're going to have a lot of problems during and after treatment. This is related to the appliance. So type of appliance, it does matter. Which case do I choose the appliance? Which appliance do I choose for which case, which age, and what are the factors that prevent me from choosing this appliance or another? I'll skip these, or actually no. I'm okay in time, right? Yeah, okay. So if we go for the material of the appliance, we have stainless steel, we have ceramic, we have Invisalign, or aligners, which are made from plastics, and we should make sure that the patient does not have any allergy from any of the component of the appliance. And then mechanism of the ortho appliance, I should know how does this appliance work. If I don't know how does it work, I'm just wasting the patient time, and I might complicate the treatment for him. I might complicate the case for him. So, and then we have the relation between the ortho appliance and the structure. So if we have a braces inside, we should know, or we should tell the patient that you're going to have some ulcers, you're going to have some pain, and all of these things. So you have to be knowledgeable of what you're using and where you're using it to prevent any complications and to minimize the risk for the patient. So what are the complications and risk of ortho treatment? We have a lot. We have a local and we have a systemic. Local include dental, periodontal, TMJ, soft tissue, and the unsatisfactory outcome of ortho treatment. Then we have systemic effects, psychological, gastrointestinal, when the patient inhales some of the appliances, allergies, cardiac, chronic fatigue syndrome. When we start with the patient really early in age, then we're just wasting his cooperation or burning his cooperation, and then we have cross-infection. I won't go through all of these. I will just focus on those that are related to malpractice by orthodontist or a dental practitioner, or unknowledgeable. So I'll pass through all of these. So Enamel damage. When do we have enamel damage? We can have enamel damage from starting before bond up of the patient, where we prepare the patient with using a pumice, prepare the teeth using a pumice. The pumice can cause some surface irregularities. These irregularities can affect the appearance of the teeth. This is number one. And then we have, during bonding, there are different type of bonding materials. We use resin, yes, but we have chemically cured and we have lightly cured and lighter cured. And the chemically cured has been proven in the literature that they do cause more harm to the enamel than the light cure. The bonding we're using, conventional versus self-etch. The self-etch has a lower bond strength, but the conventional bonding does cause more harm to the enamel than the self-etch. So you have to weigh the risk and benefit. So if I have a patient with, let's say, a poor oral hygiene where I can get the bond, the brackets off more easily, then I will use the conventional, conventional bonding, and I will use the chemical cure. But then if a patient with a good oral hygiene, I would use the self-etch bonding. And then during bonding the orthodontic appliance, if you are not aware, if you're not trained, if you don't have the knowledge, then you might put the bracket in places where it can cause harm to the other teeth. So if you put it in if you put, let's say, ceramic brackets in the lower anterior, where in a deep bite cases, then you're going to affect the upper anterior teeth enamel. And in some cases, like for example, in the canine relation, is the same. If you're retracting the upper anterior teeth and you have the canine brackets, lower canine brackets hitting the tip of the upper canine. So you have to know where are you going, and for you knowing where are you going, you have to have the knowledge and the ability to imagine what's gonna happen step by step until you reach the end. During debonding, the aim for us when we debond is to break the bond. We have enamel, we have resin, and we have the bracket. So where do we want to break the bond? Where? Between bracket and resin, or between resin and enamel? What's the ideal? Bracket and resin, yes. But in some cases it's tricky, especially when you have ceramic brackets. So you have to know how to deal with it, or how to make it happen that it breaks between the resin and ceramic, in order to prevent any fractures in the teeth. And it has been shown in literature that 97% of orthodontic cases who have brackets bonded to their teeth, whether ceramic or metal, have cracks on their labial surface. And under a high microscope, high power microscope, they found some cracks in the lingual surface. Enamel decalcification and decay, it's not just on the patient's head or shoulder. It is our job here to prevent this. Because once we bond the bracket, then there is around 5 times more streptomutans in the saliva. There is more plaque accumulation and decrease in the salivary pH. So you have to know these in order to know what to do to prevent this happening. And according to literature, this stays in the mouth for 1 year post-debond. So it appears like this, and I don't think any of your patients would be happy after you debond the braces having this appearance in their teeth. And it's more in the gingival and distal aspect around the bracket than the incisal part. So 70% of orthodontic patients will have enamel decalcification, and 30% of the 70 are in maxillary incisors. 5% of them become decayed. And for that, we have to choose type of braces The least that can cause enamel decalcification are the aligners, but are the aligners good for every case? In my own opinion, no. Aligners cannot do every case. Although they claim they do, they don't. But the elastic modules around the brackets, it does cause more accumulation of plaque, more than the self-ligation. So there are some factors that you have to take into consideration, and it's on your shoulder to monitor his oral hygiene. You have to make sure that he's doing a good job cleaning his teeth during his braces. And it's on your shoulder to select the case. If the patient has a bad oral hygiene, I do not start. Yeah, he's going to pay me a lot of money, but then I'm going to end up with a bad result. I don't want that to happen for me. It's affecting my reputation. So it's in our shoulder, although the patient is controlling that. Okay. Tooth color alteration. Basically, 80% of the ortho patients, 80% of ortho patients do suffer from tooth alteration, tooth color alteration after debonding. And with that, I don't mean enamel decalcification. It is basically related to the resin tags that are in the enamel for the bonding. And because these resin tags will cause some surface roughness, will change the texture of the tooth. And this is, I don't think the lighting is helping me here, but this is one of my cases, and there is a clear difference in the color of the teeth. It's not, although both photos has been taken with the same, let's say, same settings of camera, in the same place, same position, but it does change the color of the teeth, and we have to put that in mind. External apical root resorption, 100% of cases will have root resorption, but it's usually between 1 and 2 millimeter. So why, if every case is having 100%, having a root resorption, why would I care? Why would I say it's on the orthodontist shoulder? I would say that because there are so many predisposing factors that will lead you that this case is going to have more resorption than the other. And it's on your hand to alter the dosage of the mechanics and prevent that happening. Does it cause mobility of teeth? 5 minutes. Mobility of teeth? Rarely, it's around a grade 1 mobility. Okay. Periodontal complication, if you have a patient, again, it's on our shoulder to assess the patient in the beginning, and to see if he has any perio problem, then we have to make sure to alter our dosage. And this thing has been discussed in the cases earlier. I think Dr. Abbas mentioned that. So, temporomandibular disorder, it's debatable. Some people will say, ortho will relieve TMD, and some people will say ortho will cause TMD. In my personal opinion, if you end up with the equilibrium occlusion, then you're not going to have a TMD. But again, it's on your shoulder. If you have the knowledge, then you're going to make it. But if you don't have the knowledge, then you don't, and you won't be able to do it. Profile damage, I won't go there. There was a lot of lectures here about profile and how can we improve it. So we do improve a profile or we damage it. And it's with us choosing the mechanics, the type of treatment, and the appliance we're using. Won't go there, was going to discuss more. So here I come. My conclusion is, this brave man, this scientist said that for every action there is a reaction that is equal in the magnitude, right? So if I apply a force without knowing where am I applying this force, I will have a reaction. Don't tell me, most general dentists these days, they say, ortho is easy. We just put brackets, they're going to straighten up, and we're going to have the result. Don't tell me you're going to do this easy without having the knowledge how the teeth move, where do they move, and what are the accompanying structure in the face. So my advice, please, every orthodontist here is a dentist, but not every dentist is an orthodontist. Orthodontics is one of the specialties like implantology, like a max fax surgeon that needs more specialization. I cannot just go and say, I want to step my feet there. For me, as a person, I didn't do endo treatment since 1999. And for that, every patient comes and says, no, we're coming for you, we want you to do for us. And I say, if I do it for you, you're gonna end up with extracting that tooth. I know my limitation. So I just ask every general dentist not just to say, okay, I know how to swim a little bit, then I'm gonna go into the sea. No, you have to know what you're doing before you go and do it. That's me. Part of me was in Belgium, part in Germany, and the other hand was in Netherlands. You cannot do that and try to work and do everything, because you must have your hand and you have your mind concentrated on one thing to be able to succeed. But in this way, I won't go anywhere because I'm just sitting there trying to hold Germany, put my hand in Germany, my leg in Belgium, and in the other hand in the Netherlands. Thank you so much, and I hope I passed my message.
Thank you, Dr. Lina, for this valuable lecture.